Dr Nick Coatsworth is an infectious diseases physician and former Deputy Chief Medical Officer. Now, he's been writing and speaking about Australia's current strategy in relation to essentially going for an elimination strategy and how feasible that is into the future. And he joins us now. Welcome to the program.
Thanks very much, Patricia.
Just starting on that Qantas issue, is Qantas right to be standing by the results of its initial swabs of passengers booked on repatriation flights?
Well, Patricia, I'm not exactly familiar with the lab that's doing those tests, but I think what we do know is that this is a process that we need to go through to actually allow Australians from what we call highly endemic countries where there's lots of COVID-19 to undergo testing before they get on that plane. So as we know, we had that hiatus of 2 weeks where the Biosecurity Act was imposed, and that was the very first flight out of India thereafter. So there's obviously some teething issues that are going to have to be worked through there. And like we said, viewers will remember that back in the first wave, when we had situations where even the PCR tests were positive on one day and negative on the next, and I think for some people were positive the day after that those tests are by no means 100% perfect every time.
Is it possible that the initial results were all correct and the subsequent results from other labs are wrong?
Look, it's entirely possible, or it could be vice versa. I don't have enough information to make that call, but the important thing is that no test is perfect. And there's an interesting concept where the higher the likelihood of you finding a person with the disease, the greater the likelihood of you getting what's called a false positive test. So that's a sort of well-known concept in medicine, but we want the tests that we use to find everybody with the disease. And by definition, they will also test positive some people who don't have the disease. And that's always going to be the challenge with medical testing.
What do you make of the argument that Qantas should offer the passengers fresh swabs to be analysed at a new laboratory?
Look, again, it's a hard one.
But isn't it reasonable given the discrepancy?
It sounds like it could be a reasonable thing, but again, I'd have to look through that process to analyse it a bit more clearly.
Let's move to another issue, and you've been speaking about this controversially. Isn't a quasi-elimination strategy the right approach for Australia until we're fully vaccinated?
Yes. Yes, it is, and okay. I don't think I wouldn't actually dispute that at all. The issue is when we are fully vaccinated, what risk appetite are we going to have? And what I guess I'm worried about, and what I was reflecting on in the speech last week, is that we've created with our success this deep risk aversion to COVID-19, which won't necessarily be a valid position to base our policy on when we've got a majority of Australians vaccinated. So that's I think the conversation best had now before we want to open international borders in a staged approach in 2022. Okay,
so let's go to what that rate should be, because is it about 62%? I think that's she didn't go to the percentage, but the Premier Gladys Berejiklian talked about a sort of number of jabs in people's arms. That would be about 62% of the New South Wales population. Is that a reasonable amount of coverage before you look at opening up the borders?
I certainly think personally it needs to be greater than 60%.
So
but
what should it be in your view?
It shouldn't be me deciding upon that. It should be the Chief Health Officers of Australia and the Chief Medical Officer who will present a number. But as we've seen with any number that's presented, it's never going to be perfect. It's just going to be based on the best evidence at the time. But what do we know at the moment? We know that in the United Kingdom, with 56% of eligible adults vaccinated with their first dose, that a Monday a week ago, they had zero hospitalisations, zero deaths, I should say, zero deaths after all they've been through. And that's at 56%. We know that in Israel, with 80% of their elderly population vaccinated, they've had a marked reduction in hospitalisations. And we know that in the United States, the Centres for Disease Control has changed its advice on mask wearing for people who are vaccinated. So the message to Australians, I think, is this is a different disease when you are immune to it. Clearly, but that the amount of protection you get from immunity and vaccination is very, very significant.
Okay, so you think, I know the Chief Medical Officer will make the ultimate recommendation, but in your view, 62% is too low. What would the level of vaccination percentage need to be across Australia for us to realistically be able to open the borders safely?
Well, look, because that target is going to be something that has to be set by the chief medical officers, because it's not going to be perfect, I really don't think it's helpful for me to speculate on it. What it does depend on, though, is what our risk appetite is. So if, for example, you have a situation where the community does not accept that we should have any community transmission of COVID, then the level of vaccination is going to be far, far higher, perhaps even unattainable, in the order of well in excess of 90%. Whereas if we accept that there will be a degree of COVID that can be managed within the community with our health system, with small numbers of COVID positive patients who are ill getting into intensive care potentially if they get unwell, then that number that you need to have vaccinated is clearly a lot less. So that's why I raised the discussion last week, because whatever your principle is about COVID circulating in community effectively dictates how many people you're going to need to be vaccinated before you open international borders.
And what should that risk be? What's your view about what kind of risk we should be prepared to take on?
Look, I think we should be prepared in 2022, we should be prepared to test our healthcare system, to really test our public health system, and to look towards the data that we'll get from the rest of 2021 when we see many more countries, not just Israel and the UK, but many more countries reach high vaccination rates. And that will give us the data and the confidence that we can cope with COVID-19 within our community.
Does the emergence of second and third waves in Asia, where the pandemic had been well managed, demonstrate the dangers of opening up too soon?
It does, but again, the numbers of people within those communities vaccinated was nowhere near what you would expect to attenuate the effect of the virus. So I think if we start seeing waves of COVID-19 in vaccinated populations, people 60%, 70%, 80% vaccinated populations, then that's a real worry. But there's no evidence that that's the case. In fact, exactly the opposite. That those populations, communities where we are getting those sort of vaccination levels, even with the Indian variants, the UK variants, and the other circulating variants around the world, that we still get good responses to the vaccination campaigns.
Now, the Virgin CEO made some pretty controversial comments yesterday that the Prime Minister has criticised, that we need to open the borders even earlier and be prepared that people will die. Quite obviously very crude remarks, but is she right that we need to be prepared if the borders reopen, that some people will die in Australia of COVID-19?
Oh, look, I think that is a very premature discussion to be having, because we do have a vaccine that's effective. We do have vaccines that will prevent people from getting hospitalised and into intensive care. So the discussion is about preventing that, not allowing that.
It is, but even you told me earlier that you do, if we open the borders and we're testing our public health system, we're going to have people in intensive care. Not all of those people who go into intensive care will be able to be saved. So inevitably, there will be deaths. So how is it premature? It's an inevitability, isn't it? And
well,
that's also something we have to talk about.
Look, we do need to talk about it, Patricia. I think you're right, and I did say that. I think in 2022, when we've got significant numbers vaccinated, we will have access to ICU beds. And so there will be a risk. There will be a risk of people dying from COVID-19 if it's circulating in our community. But what we know from the studies that our intensive care specialists did in 2020 is that when Australians get to intensive care beds, their mortality from COVID-19, the chance of them dying, is far less than anywhere else in the world, because we've got such a good system. So the idea behind vaccination, of course, is to not find these situations where your ICUs are overwhelmed, you don't have enough beds, or you have a very high proportion of elderly Australians getting COVID-19, which would inevitably lead to deaths. So if you vaccinate your elderly population, you protect them, and then you've got sufficient access for the rest of your population, then you're highly likely to survive COVID-19.
So should the international borders, on your logic, be open before July next year?
No, I don't think so. I don't think so. I mean, I think the government's been very clear that the vaccination campaign is extending throughout 2021. And then my view is that there needs to be a staged, cautious approach. Like I think nearly every commentator, clinician, doesn't matter who you ask, or indeed the PM, is advocating for a staged, cautious approach to opening, rather than sort of opening to like it's a sort of iron door opening or closing.
Do you believe there was immediate recognition, clarification and acknowledgement of the problems with the COVID Safe app? And I use that language because you did say it in your speech that when mistakes were made during the crisis, it was all rectified. But did that happen with the COVID Safe app?
Look, I think with the COVID Safe app, it was an issue of probably uptake more than anything else. And if I remember correctly at the time, the number of downloads was extraordinary. But if I looked back and thought we should have done anything different with the COVID Safe app, it would have been perhaps promoting it more after it was released rather than accepting the 5 million downloads. But
I don't mean to be rude, but I have to be. I downloaded it. The thing doesn't work very well. Yep. With respect. I don't think it's about the downloads. The thing doesn't actually do the job it's meant to do. It's barely helped in contact tracing. The actual app is flawed.
So if I can just... no, it's not being rude. It's not being rude at all.
No, it's being truthful.
I think it's fair to say that there hasn't been an app worldwide that's been particularly successful, but it's not fair to say that it didn't do anything. There was a very significant exposure event in the order of several hundred. I think it was up to 500 people in Western Sydney that was detected by the COVID Safe app. And then, of course, you have to ask yourself, was that worth the investment? But when you consider what might have happened with a COVID outbreak in Western Sydney that was left undetected, then I think that investment was worthwhile. Was it perfect? By no means. Could it have been better? Of course. I'm not an IT expert, but I'm sure there were ways to make that better. Keep in mind that the development of that app was not just undertaken by the department. It was undertaken with some of the best IT minds in the country, external to government as well.
Yeah, and got paid handsomely. Did you acknowledge aerosol transmission or question the advice of the infection control advisors who downplayed the risks?
I dispute that the risks were downplayed. I mean, I think this is a really important thing for us to clarify, because I know there's individuals out there, my colleagues, who feel as though the advice didn't move at all. Every time we talk about advice in COVID-19, we wish the advice had moved quicker. There's no doubt about that. But I remember distinctly the conversations. It wasn't simply the infection control expert group. It was myself. It was CMOs in Victoria. It was deputy CHOs talking about that Royal Melbourne outbreak and when we needed to change the advice. And the advice was based on the case outbreak that was published in the Royal Medical Journal of Australia in the Royal Melbourne Hospital, where ventilation and N95 masks were clearly an issue. So, could it have been done sooner? Of course, anything with COVID-19.
It definitely should have, but let's just I just want to nail you down on this. Of course it should have been done sooner.
Well, I don't know why we would say that, though, Patricia.
Because airborne transmission has clearly become... Look at all of the incidents we've seen in hotels, for instance. We're talking about airborne transmission being at the centre of this.
Yeah, when we say all of the incidents that have happened in hotels, we don't have conclusive evidence that is airborne. I think it's fair to say that some of those were airborne. But remember, we're talking about risk here. We're talking about thousands of Australians, if not hundreds of thousands of Australians, coming through hotel quarantine, and a handful of transmission through the airborne route. It's about the extent to which it's transmitted by the airborne route, as much as the fact that it is transmitted via the airborne route as much as other routes. So that idea that there's now spectrum and that the old dogma of contact and droplet versus airborne isn't valid anymore, that is an accepted viewpoint by the infectious disease community in Australia. And what I was referring to in the speech was that it's not reasonable for individuals to say that the advice has not moved in the 12 months of COVID-19.
I think some of the critique is that it's moved too slowly. But let's move on to another issue. What are the implications of AstraZeneca's reduced effectiveness against variants, including the South African strain, for people who do get that vaccine?
Well, I dispute that the evidence is very strong that that there's a reduction in effectiveness against those variants, and this was one of my points in the speech, of course, that I think those issues with the AstraZeneca have been substantively overplayed by people who, for reasons best known to themselves, do not support the use of the AstraZeneca vaccine. Let's look at the best comparator that we have, which is the United Kingdom, which has a mixed Astra-Pfizer vaccine program, has had extraordinary results, even with some of those variants, and the studies remain very small, suggesting that Astra might be less effective against the South African strain. So I sort of dispute that there's a body of evidence there. I would also point out that in terms of global health, AstraZeneca is the company that's offering this vaccine at cost, rather than making a margin on it. So I'm just not sure why the vaccine is as maligned as it has been, given its clear effectiveness and safety.
Just finally, before I let you go, and I've taken too much time because I wanted to pick your brain about some of those big themes, but let's just talk about the vaccination rollout. Only 4% of people in disability care have been vaccinated. That's not good enough, is it?
Oh, well, I think that one of the senior bureaucrats in the health department at Estimates yesterday or during the Royal Commission yesterday, did acknowledge that that is far too slow. So I don't think there's any dispute on that, but that the priority was given to aged care residents, and I think the results in the second wave in Victoria sort of speak for themselves there in terms of that prioritisation decision. I mean, we've hit 3 million nationally, and we've moved through 1A, 1B, and now we're opening up to 40 to 49. Yes, again, it's a little bit the same as the discussion we had on airborne transmission. It is slower than anyone would like. People want things to go a lot quicker, and they can and will go quicker now that supply is a little bit more freely available at general practice, but also at the mass vaccination clinics.
Thanks so much for your time.
Thank you.
Dr. Nick Coatsworth is an infectious diseases physician and former Deputy Chief Medical Officer. Heading overseas, US President Joe Biden has